Recording in progress.
Good evening and a warm welcome to all the viewers on a E-Gurukul series of episodes of surgical skill transfer and solving critical dilemmas by a teacher par excellence, Dr. P.C. Mahapatra. A very warm welcome to you, sir. Today is the 21st episode, and the topic for today's episode is fertility promoting procedures in gynecology. I once again welcome our speaker for tonight, and Dr. P.C. Mahapatra. With your permission, we open today's session. Over to you, sir.
Thank you, Team Juventus and the organizers of this brilliant E-Gurukul program. And now we have reached almost about 21st episode, completing the 20th episode on the various aspects of gynecological surgery and the skill transfer. The same theme is constantly being maintained. But before going to this topic, I think I again welcome all the viewers and my friends, philosophers and guides, my students, my colleagues, my teachers, for again, after a long time, there is a pause. I fully agree that it is because of some unavoidable circumstances, and my sincere apology for doing that. And that's why I thought that this month at any cost, even if it is other than Saturday, I will do it. And that's why I'm here today on this Thursday instead of this Saturday. And I again welcome all of you. The waves of corona might come, the various strains might come, the Delta might come, the Omicron might come, but our E-Gurukul program will be going on. And today I'm there in the 21st episode. Again, I welcome all of you and start this episode. And this is a Juventus initiative. And when it was proposed, I thought I always tell that I'm digitally very, very poor and physically very, very strong. But these Juventus people have made me physical as well as digitally strong. Rather, they have taken over the digital aspects of weakness of mind and make this stronger in this E-Gurukul program. And thanks all the Juventus team, starting from Dr. Diwan and Alad and all the medical team and the events and the organizers of this fantastic program for that. Again, I bring greetings from the place of Lord Jagannath, and let this Jagannath solve all our problems, all the clinical dilemmas be solved by the great Lord. Well, as usual, our philosophy is to target on a particular subject, a focused subject, and discuss about that, and sharing my knowledge, my experiences, and my surgical practices before all of you. And today, we will deal with the fertility promoting procedures in gynecology. And what are the surgical options, the tips and tricks? Well, it is not only important for the infertility specialist, those who are really doing more of advanced procedure of ART procedures, but it's more important for the general gynecology. Day in and day out, you see fertility patients, and the practical management in relation to surgical aspects of the various parts. I think today's topic will be mainly focused on that. Well, the evolution of this fertility promoting surgery, it dates back to long years, and the documented evidences was Ephraim Magdwell, 1809 of Dan Valley. It is not only the fertility promoting procedures. He is called as the father of, I think you talk about hysterectomy, you talk about myomectomy, you talk about ovarian tumor. And this was one of the incidents where he operated the cousin's wife of the Lincoln and President Lincoln. And then it was a huge mass. And he thought that it could be my ovarian tumor. And he was the first person to start this surgical procedure for that. And with a lot of risk, and the patient coughed, and the whole mass came out. And it was a pedunculated myoma. and successfully performed this myomectomy during this procedure. I'm not telling that this is mainly for the fertility procedure, but it's a surgical history in gynecology, which everybody remembers Ephraim Magdwell. Well, as far as the fertility promoting procedure is concerned, way back in 1840, Amuset was the first person who did the first successful myomectomy. And at that time, it was proven that it could be a cause of infertility, and therefore myomectomy was performed. Later on, 1898, Alexander Adam, he published 11 cases and reported 11 cases of abdominal myomectomy. The details of the procedure has not been documented, but this was really a great series at those times, where in the pre-anesthetic and when the procedures where diagnostic facilities are not available. Well, the father of myomectomy, we all know Victor Bonney, a great surgeon, and he developed the skill and popularized the procedures of myomectomy. Not only single, the record shows the number of myomas in one sitting is recovered about more than 100 myomas in way back in 1923. And we know that the different modifications of these procedures, the Bonney's myomectomy clamp, he devised, and Bonney's myomectomy hood, he devised, and the details of the primary incision, secondary incision, and how to do a suture and obliterate the dead space. I think we learned from that Victor Bonney way back in 1923, when the knowledge of anesthesia again was very, very less, and more so the transfusion. I think these are the cases where with a lot of risk, and we must salute today when we discuss about myomectomy and infertility patients. Again, a revolution came in 1935. Everybody, every gynecologist knows these two great researchers, Steen and Leventhal. And Steen and Leventhal is very, very known to all gynecologists, that the Steen-Leventhal syndrome, which now is more commonly discussed about polycystic ovarian syndrome. And they did it with 7 cases. They did about 28 years of research. And clinical research, when again sonography was not there, reproductive endocrinology was not there. At that time, mainly on the clinical basis, they diagnosed this polycystic ovarian syndrome, and they revolutionized one surgical procedures for the polycystic ovarian disease, that is ovarian wedge resection, bilateral ovarian wedge resection, in which they could be able to have a successful pregnancy in 2 of the cases, and all 7 cases resumed normal menses and continuing the normal life for that. And that was a remarkable event and popularized, and everybody was really, when we talk of PCOD, I think Steen and Leventhal comes in mind. When we talk of ovarian drilling, then the Steen and Leventhal comes in mind. Ovarian bilateral ovarian wedge resection is one of the successful stories of ovulation induction by surgical methods. And now it has been reflected or contemplated and transferred to the endoscopic era by the laparoscopic approach. The concept is again the Steen and Leventhal concept. Now, as far as the infertility is concerned, again the surgical factor in infertility or fertility promoting surgery, George Aronet was the first person who established way back in 1950 in Royal Victorian Hospital in Montreal, Canada. And this is named as the first Canadian infertility clinic, where George Aronet, they started doing the coldoscopic procedure by knee chest position. And that was not only the infertility clinic, but something endoscopic visualization of the pelvis. He was the first to find out the concept by this coldoscopic approach. And then emergence of conventional surgery in infertility came forward, 1950s onwards. Many surgeons all over the globe, they did the conventional surgery in infertility. And microsurgical procedures were very popular in the 1970s, when the tubal factors and tubal, the cuff salpingostomy and the tubal anastomosis, the reconvolution procedure were very popular in this 1970s. Well, the landmark revolution of fertility promoting surgery came when endoscopy became very popular, way back in 1980s onwards. Well, before that, it was strictly limited to the diagnostic parameters and diagnostic procedures. When the video laparoscopy came, and many of the advances in the camera or the gadgets, as technology has improved, till today, there is a lot of advances starting last, say, about 44 decades. We have gone through many advances in the technology, in the instrumentation, and therefore, again, the laparotomy or the conventional surgery has drastically come down, and promoting the infertility, especially infertility surgery by laparoscopy and hysteroscopy. So this is a landmark event until today also. When we talk of fertility promoting surgery, endoscopy comes to our mind first. Now, in gynec malignancy, oncosurgeons, they also saw that it's not the predominant, it's not the prerogative of elderly people in young age where the fertility is warranted, fertility preserving surgery in gynecological malignancy. I think these are the surgeries which have already been practiced, popularized by gynec oncologists, and starting from the radical trachelectomy to the conservative surgery of the ovarian tumors. These are the two areas where the fertility preserving surgeries in gynec malignancy is there, and provided the stages are in the early stage, I think these are the cases where they go for a conservative surgery rather than the more radical surgery for that. Again, remarkable revolution is the uterine transplant and ovarian transplant. We know that uterine transplant is not only being popularized in Sweden and all over the globe, but here in India also, our Indian surgeon has popularized it, not only popularized the new innovations by using the endoscopic approach, the uterine transplant. This is one step ahead of the fertility promoting surgery, and ovarian transplant has become very, very popular, but due to some technical or surgical anatomical problem, it has not picked up very well during the all over the world, and particularly in countries like India. Well, there are some advances when we come up about the infertility surgery, infertility treatment in more advanced cases. And now the innovative technology of the cryopreservation of the ovary, when it came out, I think the ovarian tissue has been picked up and then cryopreserved. Then it could be re-implanted into the body in autologous, and that's a very important thing there. Or ovarian transposition. Ovarian transposition, if the patient is having a radiotherapy, I think you displace the ovary higher up in the paracolic gutter, and that becomes one of the fertility. It's not a fertility promoting surgery, but at least a fertility adjunct surgery for that. Salute to the great giants and the leaders who have toiled their life and sacrificed to one. George Aronet, founder of the first fertility clinic in Canada, and Victor Gomel, the pioneer of reproductive and microsurgery. He emphasized that microsurgery and the reproductive surgery. I think he's the person who has dedicated his life only for the reproductive and reproductive surgery and microsurgery. And Victor Gomel has published many books. If you read, I think refer that books, I think you can know the genius, how genius he is. Victor Vani, nothing to tell about the Victor Vani, and a salute to Victor Vani for that. And again, the founder researcher, the real researcher who has toiled hard for years together, taking only 7 patients and finding out the novel approach of the bilateral ovarian wage resection, Stein and Leventhal. Well, endoscopy, we know that it has really gained a momentum in gynecology, in every field, and particularly in fertility. But still, when it was there up till 1980s, we were also involved in conventional surgery in infertility. And today also, we cannot say that conventional surgery has gone to the graveyard. Although the dominant majority of the cases, we go for endoscopic procedures. But before endoscopy, the surgeons were also doing a myomectomy. The surgeons are also doing an adenomyomectomy, ovarian tumor, including the endometriotic cyst also, and tubal surgeries like microsurgical techniques and reconstructive surgery in genital prolapse. So now, still there is a place. One should consider that all the cases may not be subjected or may not be feasible for endoscopic procedures. And some of the cases, I personally feel that, yes, I also do in the present status, along with the endoscopic procedure, some cases where we do an open myomectomy, conventional myomectomy, or adenomyomectomy, even ovarian tumors also, where and especially in cases where there is a suspicion by the collar Doppler, we have a provision of a frozen biopsy, and then if we select it as a conservative procedures and a fertility promoting procedures for that. Tubal surgeries, microsurgical techniques, the tubal anastomosis following the reconvolution or the tubectomy and reconvolution procedure. I think we have done, my experience goes that yes, on microsurgical techniques we have done more. I think now the younger generations, of course, for the last 2 decades, they have started doing an endoscopic reconvolution procedure, and they are really at par with the conventional procedure, even better than the conventional procedure with that, because of the magnification and views, and therefore the anastomosis between these two ends of the tube gives a better results because the fibrosis, the adhesions are relatively less. Same thing with the cuff salpingostomy. When we were students, we were being taught, and we have seen cuff salpingostomy is being done, open cuff salpingostomy by again the Zen 60, the Vicryl or 60 proline, and reconvolution is being done. And many cases where one is not having an expertise of doing a reconvolution by laparoscopy, maybe that they must have. I've done a number of cases of this particular case, which I will just share my experiences also. Now about the genital prolapse, again, one area where conventional surgery still dominates. Say, for example, although the prolapse now endoscopic has done by fixation with the mesh has become a mesh. But this is only because cervicopexy, which is there, the Purandare cervicopexy or Khana's cervicopexy, where we take a strip of the rectus sheath and fix it to this anterior portion of the cervix and fix it in case of nulliparous prolapse. Now, this has been already by laparoscopic procedures with the tacker or with the suture, they can use it with the mesh fixing at that, and that is one aspect where it can be done. Fatherless repair, again, a fatherless repair, the patient is young, she is keen for a second pregnancy, and she has come with either a secondary infertility, and we find that there is a prolapse, second degree descent, and cervix is unhealthy, hypertrophied. Those are the cases I think there is still a place for fatherless repair. A meticulous repair is essential, not just to promote fertility is one, and then second is not to have a pregnancy loss, because the amputation, at which level the amputation will be there, and beautiful reconstruction of the neo-cervix is mandatory in those cases of fatherless repair. Now coming to again endoscopy, which really prevails as a dominant surgery in fertility promoting, the facts and fallacies. It has expanding horizons, advancing technology, as I've already told. We have gone from the single chip to 3-chip camera to the 2D HD camera, and now the 3D camera, and of course the 4K. I think 4K Rubina by Stars is a wonderful camera, and advanced technology is there. Apart from that, the gadgets, other hand instruments are really promising for that. Improved skill, I think the you people, the generation when we goes, my skill as compared to the next generation of yours will be a completely different thing. I wish that the skill will be manifold magnified than me if you compare with that, and therefore you are more skillful the next generation. You can do better surgery than what I do and everybody in this age does. Now, one thing I will mention here, IVF versus endoscopy. There is a debate now. Gone are the days, about a few decades before, about 1 decade before also, when we say the result, everything boils down to result. And fertility clinic, I say that I have done a study and I have done a survey where IVF unit or assisted reproductive unit, wherever is there, if it is not have the provisions of endoscopy, I think that it is something deficient in that. And that was my belief. And when I started do it in my unit also, I thought endoscopy is one of the very important part of ART clinic. Though ART clinic may be without endoscopy unit, but if there is an endoscopy unit, ART procedures, I think it's more simplified and seems complete in my point of view for that. Now, we have seen that the cases where endoscopy has been done, I think the results of infertility is really improved for that. We know that by endoscopy is there, and they are not subjected to IVF, a very costly procedure than the endoscopy procedure. And second important, once it is corrected, again it subsequently they can go for the number of pregnancies, or a second para, third para can be gone for that. Now, because the result ultimately boils down to IVF result. The IVF result has drastically improved for the last decade or so. When the IVF results have increased, I think it is obvious that the endoscopy, I think, procedures must decline for that. And that is the debate between the fertility specialist and the endoscopist. In many cases, they do not reach at a common agreement. They differ with that, but still we say that IVF results, when it is increased, I think the incidence of the procedures where endoscopy is usually advocated in all cases, basing on the declining IVF results, we do the procedure, and that is now a debate for that. So IVF has been, and now the judgment is important by the gynecologist or endoscopic surgeons and fertility specialists, because I have seen the opinion, if you have an IVF people, they always prefer for IVF rather than for the endoscopy. When you go to an endoscopist, they will say that yes, endoscopy is important, but it is not the mood of the endoscopic surgeon or the IVF specialist. It is the need of the patient. There are many factors which controls and decides whether to go for IVF or go for endoscopy, but it's definitely a complementary procedure. There is no doubt about it, and it's one of the essential procedure. And before IVF also, that is my concern. That is my opinion for that. Of course, future, wherever it goes, we do not know whether IVF, if some other new modalities might come, where you say that yes, you just give some of the medical management and whole thing is gone. Say, for example, endometriosis. A medical management, if it improves, and the role of an laparoscopy or endoscopy procedure will vanish for that. And therefore, future, I'm waiting for the future for a novel mantra for infertility, so that you do not have to do endoscopy, fertility promoting surgery, you do not have to do IVF also. You enchant a mantra and get a baby for that also. I'm dreaming for the future for that. Now, endoscopy in infertility, therefore, we will make a predominant deliberation today. And D. Cheney has written about 2 decades before, in 2002. I read that D. Cheney had come to India and he told that yes, the obituary of laparotomy for reconstructive pelvic surgery has already been written. It's the publication that remains. It's the person of 2002, way back in 2002 by D. Cheney, who has told that yes, emphasizing that how the success rate of laparoscopy has gone more advanced, so that the obituary of laparotomy has been already written, and therefore we say goodbye to the laparotomy. But still, in some cases, as I told, laparotomy has a place for that. And yesterday's contraindications are today's indications. The cases where in difficult, complex reconstructive surgery, which is not possible yesterday, I think they are called as the contraindications, are now today's indications for that. So therefore, the scope of scopes has broadened from anti-fertility to pro-fertility, from benign to malignant, from elective to emergency, from simple adhesolysis to complex reconstructive surgery. And it is not only limited to the diagnostic procedure as in 1970s, 80s. Now we're going for a more advanced therapeutic procedures by the endoscopic procedure. Now, when we come to a female infertility evaluation, for the general gynecologist, all of you do a clinical assessment, a biochemical assessment. Sonography is a very important, I think, gadgets. And now the real-time sonography and the advances of imaging technology has really solved many issues. The 2D, 3D sonography with the color Doppler has a boon for not only the diagnosis, but it will guide you as far as the therapy. And of course, the details of the endoscopy I will highlight. Now, first and foremost, is a common procedure is in gynecology and infertility is a diagnostic hysterolaparoscopy. DHL, the hysterolaparoscopy has become part and parcel of the gynecological as a first tool for infertility investigations for that. But again, I say What is the purpose? The purpose, you have to understand, you have to diagnose, you have to treat, and you have to counsel also. And I believe that an eye to the pelvis is superior to two fingers in the vagina. And therefore, hysteroscopy has become an essential or a mandatory method of investigations for infertility for that. But remember, as I have already told, don't misuse it. Many people that, is it a be-all and end-all in infertility evaluation? Is it that all patients who come to you in infertility, you have to do a first hysteroscopy? I think be cautious about it. I really condemn this. There could be some indications for that, the selection of cases where you do a diagnostic hysteroscopy. There must be some criteria for that. You look, what for you look, the diagnostic hysteroscopy gives an idea or the nature of pathology inside of the uterus, outside of the uterus, the pelvis, the ovary, the tubes, and the patency, and the pelvic adhesions, and the pelvic diseases like endometriosis. So these are the cases, these are the points for which we do a diagnostic hysteroscopy. But for years together, we were doing the HSG, and again the controversy comes. If HSG is there, now HSG, shall we go discard it to the graveyard in the present setup of high tech where these cases could be better visualized by DHL? Well, no, it is not I think, substitute. It is a complementary procedure because HSG, hysterosalpingography or sonosalpingography, these are the methods to evaluate the tubal pathology. There is no doubt about it. And along with that, the cavity abnormality can be very well delineated by the hysterosalpingography. But there are some limitations of either of the procedures of hysteroscopy or diagnostic hysteroscopy. So my practice, always I say, they consider that age is a very important criteria to then decide whether to go for a DHL or not. DHL, diagnostic hysteroscopy, age is very important, advanced age. Nowadays, more commonly, they come at more than 35 years, late age of marriage, or a career-seeking women. I think these we find more often. And these are the cases, you don't wait for long, and this is the cases where the first, this is a more indication for hysteroscopy than HSG, age. Then the duration of infertility, 3 years, more than 3 years. I think these are the cases you go for a hysteroscopy rather than HSG for that. So in a case where 25 years with 1.5 years of marriage and keen for conception since trying period is 1 year, I won't advise without any symptoms that they go for a DHL. These are the cases where HSG can be also used in the present text for that. So the age of the patient, age of the female, the duration of infertility, then the symptomatology. Very important is the symptomatology. If there is a symptoms of dysmenorrhea, if there is a symptoms of pain abdomen, and these symptoms really will be in favor of the hysteroscopy, because one of the commonest finding we say that the endometriosis may be a grade 1 or grade 2 or advanced endometriosis. This could be diagnostic gold standard is hysteroscopy. So this is one area where the symptomatology dictates the procedure for that also. The next is the treatment. Already she has received multiple treatment. We find many cases they've already done ovulation induction, even follicular monitoring, everything they have done it, even they are 2 years, less than 3 years of marriage. These are the cases. Again, DHL has to be done for that. And of course, the last is when we sonographically, we find some pointers, sonographic pointers, then laparoscopy has to be done for that. If there is a sonographic pointers of an ovarian cyst, particularly the endometriotic cyst, or sonographic pointer of a displaced ovary or a kissing ovary, suspicion of pelvic endometriosis, these are the cases. You not only do a diagnostic hysteroscopy, you do a concurrent therapy and prepare those for this. So these are my basic philosophy and basic indications and the criteria for doing a hysteroscopy rather than the HSG. So HSG and sonosalpingography, rest of the cases I do because these are really little non-invasive. Then the diagnostic hysteroscopy, and skill is important in that. Expertise is important for that. Of course, the timing post-menstrual is the ideal time for that. And if you are during the time of mid-cycle, and you can see a corpus luteum, you can see that yes, it could be ovulation. Apart from the anatomical abnormality, the ovulation can be diagnosed with that, and anesthesia. And it's a short anesthesia and general anesthesia. And always we prefer to do general anesthesia. It is a procedure, it is a short procedure. We can do a total intravenous anesthesia. Earlier we are using the tube, but nowadays the LMA can be very well effective for that anesthesia, and all pre-anesthetic precautions and the procedures has to be followed for that. Now the technique usually you do is a very simple procedure. If you are trained, I think some amount of basic training is necessary for that, because you are going for a little invasive procedure, and endoscopy, laparoscopy procedure. The hysteroscopy is not very, very difficult, but at times we find difficulty in dilatation could be one area where you land in problem. Even experienced surgeons have failed to dilate also. So, and the technique is important. The hysteroscopy and the diagnostic hysteroscopy, we use normally we don't use this the glycine medium as a distension medium. The normal saline you use it, and with or without your endomat or a gravity method, you can use that. And in laparoscopy, again with the small bore, I think with the 5 millimeter, it is enough. 5 millimeter port and trocar, we use it and just evaluate the other. And a second port of about either 3 or again a 5 millimeter can have a detailed views of the pelvis, starting from the uterus. You go step by step. The UV space, overall UV space, the uterus, the contour, the dimension, and the POD with special relevance to the uterosacral, and the evidences of any flimsy adhesions, evidences of any endometriotic surface lesions. Then the tubes and ovaries, you must find out, and the undersurface of the ovary, the mobility and the surface lesions of the ovaries of endometriosis, and details of that, you can feel that. And the filling of by the instruments, you can fill the tube, whether it's a turgid or a normal, and that filling also can get, you can get idea by endoscopy. And then the spill of the dye. If you go for chromoperturbation, I think you can find out. And you must be very clear that if the dye has come to the POD, the tubes are patterned. No, if the POD presence of the dye in the POD, tubes are not present. This was not possible in a case where previously we were doing a diagnostic laparoscopy without a video. With the eyes, we are using it. If the dye is there in the POD, we say that its tube is free. But here, when the video is there, you take detailed diagnostic of whether which type, the left or right, both the tubes are patent or not, whether the fill is there or not, or there is a fill or spill, both are there or not. You just identify that. And if there is a preperitoneal circulation, what is the nature of the dye, what is the nature of the tube, you can find out with that. And then you can say the congenital anomaly, the Mullerian anomaly of the uterus can be diagnosed very well. The pelvis factor can be more important, is the pelvic factor, the adhesions. Even if these adhesions could be very, very in the tube-ovarian relationship is disturbed by the tube-ovarian adhesions, it is not picked up by sonography. The laparoscopy is the gold standard for that. Endometriotic surface lesions cannot be diagnosed by the sonography, and this is the laparoscopy is the gold standard for that also. And you document each one detailed because it's an invasive. You have to give a detailed documentation to hand over the patient so that in future it could be a help for the planning. And the concurrent therapy, when we find that AHL and when you find the surface lesions of endometriosis in the same sitting, we have fulguration in the treatment modality for that. And if the diagnostic therapeutic laparoscopy can be planned by the sonographic pointers or any suspicion of the disease, you can plan it and before the surgery and discuss with the patients whether you can go only with the diagnostic or a concurrent surgery for that. There's a classical thing, and the hysteroscopy, everybody can do the hysteroscopy, OPD procedure. Both procedures cannot be done diagnostic laparoscopy, histolaparoscopy, I don't say that is an office procedure because it should be under anesthesia. Only the hysteroscopy can be done under the office procedure for that. And here we find both the cavity of the surface of the uterine cavity, the shape of the uterine cavity, and rotate it to either side to see that it's a 30-degree 4 oblique. The telescope is used only for visualization of the right or left tube for that. So this is one of the, again, example. When I see that this is many times, if you're confused with that, there are some white punctated spots. And is it tuberculosis? I think these are the common thing which is gland opening. Don't be confused with that with the tuberculosis. There could be tuberculosis, there will be prominent glands along with or without the synechial bands, or with the caseous materials which could be there for that. But here we say that, yes, don't confuse with that. Many people have started anti-tubercular treatment. That's why I want to demonstrate that. This is the normal cavity with the two ostium on either side and the fundus with the endometrial surface filling with the glands. Now this is again endometrial cavity where you find the surface is very, very irregular. The surface is irregular, and these are the cases which usually present with the bleeding along with the infertility for that. It could be a hormonal anovulation or the unopposed estrogen, which has given rise to this particular case. And you can take a biopsy and find that is whether the hyperplastic endometrium is there or not. They usually with this, in addition to the infertility, they present with the bleeding, and you can do a histopathology in the same setting for that. Now, this is a case where you find the vascular markings are very, 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 very common, and you can see the whole of the cavity and go in the mid part of the uterus and turn to the right and turn to the left and turn to the down and up to find out everything. And while coming down, you see the endocervical canal. This particular case, I think the vascular thing, nowadays, the endometritis has become very, very common for that. And not only this is one of the cause for infertility, but it could be a cause for recurrent pregnancy loss. Many of the studies and papers have published that the endometritis or infections is one of the evidence of infection by the vascularity like this. Even if on laparoscopy we find that the everything is normal, there is no adhesions and other thing. This is one of the example which I wanted to show. Now this is how we can get a polyp, we can get a myoma, but this is a peculiarly an ostial polyp. You can find in the ostium there is a flap bulb polyps on either side. These are not real cause of infertility, but in cases where we designate that unexplained, we give a therapy and all that, and still it is not there, then there is a thing that you can, it could be one of the cause, and it could be you could, and the simple procedure you can just with the hysteroscopic grasper, you can turn out and remove that. But this is one of the cases where don't confuse that this is one of the significant cause of infertility for that. Now this in contrast to the gland opening, you see this is a case where the endometrium, the cavity is irregular with a band on one side. On the right side there is a band, and surface, you see that there are some caseous materials in the surface, and this is a synechial band on one side, simulating that it is a case of the septum, but the septum is the midline, but this is on the one side for that, and whole thing, and do suspicion of the cases, the confirmation is always by histopathology, and tubercular endometritis it came, and we gave a therapy for that. So these are the cases where you get an evidence, and not only in diagnosis, but it helps a great extent on pinpointing the pathology for that. This again, you put a hysteroscopy and you find that there is a beautiful space occupying lesion. At times it becomes very difficult to distinguish whether it's a polyp, solitary polyp, or a myoma. I think the characteristic difference between the polyp and a myoma is that the polyp is really a little pale, and when you do a polypectomy, you can find that the classical muscle is not there, and in comparison to the myoma, which I will show you while doing a polypectomy, show the polypectomy for that. Now, these are the cases where you can see the cavity is absolutely irregular, and we do not find anything, but there are strands. These are the synechias, which is very, very common and very, very troublesome for infertility. And remember, they're difficult to treat also. Synecia, if it is an incomplete like a bands, it is easier to just break it with the hysteroscope itself or with the grasping forceps. But a tough synecia is very, very difficult. And a complete synecia usually present with infertility, incomplete synecia present with recurrent pregnancy loss. But here we find the complete synecia also. We do a staged procedure and it is really difficult for that. This is again a method in which a vaginoscopic hysteroscopy you can do it, and you can do it with that 1.9 to 2.9 millimeter thin telescope, and without catching the cervix, without putting a speculum inside the vagina, you can go and find out that as if the external os is kissing you, the two lips are kissing you, you negotiate through the cervical canal and go gently with the small bore telescope, and you can find a clear and a very good endocervical canal. And if you go inside, you find a cavity, the uterine cavity. Same thing, the ostium on one side, the other ostium on the other side, you rotate it, and keeping the fiber, the light source in the central position, you rotate it towards one side, but the camera should be stable and don't rotate, because the orientation is very, very important. And basic tips I'm giving you in a hysteroscopy, if you put it, if you do not find anything, do not see anything, just withdraw. That is the fundamental principle. And orientation should be there. The camera, always don't rotate the camera. You can rotate the light source, the cable, but don't rotate it. Otherwise, orientation is very, very important. And basically, if you do not find anything, just withdraw and don't go blindly. Always see the black hole and just follow that. The fluid is going in front of you. That will distend, and it becomes very easier to go with that. Now, this is a cavity. Again, we find, on contrast to the other cases, we do not find the two ostium. Here is a case where only one ostium is seen, and its uterus cavity is absolutely tubular. And this is a case where we call that this is a unicornate uterus. Now, to confirm it by laparoscopy also you can do and find out that yes, it's a unicornate uterus, is the normal functioning on, and there could be other non-functioning on, which is a bicornate uterus. Well, only by laparoscopy you can differentiate with the unicornate and the bicornate uterus. But this is one of the anomaly where it can present with the infertility as well as with the pregnancy loss. These are atypical cases of a polyp. I think this is the ostium, this is the cavity you can find, and the posterior wall. It's just a floral polyp. It's just I think it's the petals which come out for that. And this is a solitary polyp. Remember, if there is a solitary polyp, it could be a cause of infertility or a pregnancy loss. But if it is a multiple endometrial polyps, it could be more hormonal, and anovulation could be responsible for that. That is the only trick you find out for that. Now, therefore, next coming to after the diagnostic discussion, let's come, what are the hysteroscopic surgeries in infertility? The areas where the infertility surgery by hysteroscopy is mainly done are intrauterine synecia, polyp, myoma, foreign body, septum, and the tubal block, particularly the proximal tubal block. Now, coming to the intrauterine synecia, the types of synecia, what are the types? I have already told that the incomplete or a complete synecia, and the technique of synecectomy. The technique of synecectomy is very difficult. The classical Osserman is very difficult to do it, and both hysto and laparoscopic guidance has to be done it for that. You have to go to the proper cleavage, otherwise you are going for a perforation for that. And synecectomy, simple band, if it is there, it is easier. Like here, we find just rotate it, catch hold of that with the grasping forceps, hysteroscopic grasping forceps, and just rotate it. Or even there is a band, you can just break it with the hysteroscope itself. The scope itself with the sheath, you can rotate it and breathe that. And therefore, it's a big, I think you can go. And very, very careful selection of power, use of power is used. Otherwise, it can be very dangerous if it goes through and perforations is there for that. And concurrent laparoscopy is essential to find out for that. And a staged procedure, many cases we find different stages, in 2-3 stages you can do, and then the post-op measures you can do either the some of the intrauterine contraceptive device, IUCD, to make it open and keep it that again the synechiae is not going to be recurred. And second important is the generation of the endometrium by the hormones, the estrogen, and therefore the estradiol is available now. The earlier we are using the Primarin, which is our lineural, we are using it, but now the estradiol, 17-beta estradiol are available. Results, as far as the results, I say always, my personal experience, I must say, fertility promoting surgery in hysteroscopy, one of the difficult, the climax, pinnacle of difficult surgery is synechia. And in laparoscopy, it is a conjugated fertility promoting surgery for endometriosis. Believe me, these are the two pinnacles of endoscopic surgery in relation to the fertility. Now, a little bit about the classification of intrauterine adhesions by hysteroscopic findings. It is divided into three: minimal, less than 1/4 of the uterine cavity involved; thin or flimsy adhesions, ostial areas, and upper fundus with minimally involved or clear; moderate, 1/4 to 3/4 of the uterine cavity involved; no agglutination of walls, adhesions only, ostial areas and upper fundus only partially occluded; but severe, more than 3/4 of the uterine cavity involved; agglutination of the walls or thick bands, ostial areas and upper cavity occluded. Now, what are the treatment objectives of intrauterine adhesions? There are some goals, there are some means. First goal is to restore uterine architecture to normal. How you can go it? The lysis under direct vision. So don't go for a blind curettage. Lysis under direct vision is the means. Prevent readherence. Either you can use the intrauterine splint, and commonly the intrauterine device we use it. Promote endometrial overgrowth, as I have already told. Dose of estrogen is important, and estradiol we use it. And verify cavity normalcy. You do a follow-up histogram or a hysteroscopy. Better a check hysteroscopy, we do it in all cases after doing a synecholysis for that. Now, this is again, you see that this is absolutely a complete synechia. I think this is designated as a complete synechia. One of my trainees did this and said that yes, this patient needs a synecholysis. I told that yes, don't be confused with synechia like this. You just depress the scope and find the black hole in the 12 o'clock position and just go. You are going to the wrong direction, and this is a false passage simulating synechia. You can see that above it, you can see that there is a black hole, and this is the normal cavity for that. So remember, diagnosis of synechia is misleading with that, and that could be misleading with the false passage. And a good orientation can serve the purpose for that. And therefore, I have also made many mistakes on that. And therefore, I correct it if there is a synechia. I think it will not look like this, and this will simulate for that. This is a synecholysis I was demonstrating again with the semi-rigid hysteroscopic grasper. And these are the cases, the whole cavity can be formed very well for that. This again, you can see synechial bands is absolutely as if it is simulating like a septum, but it's not septum, it's on one side, it's not in the center, so that it is there. And on the distal part of this, there is a completely, you find a band, whereas the distal part is completely, the cavity is normal. So here, either you can use the Caesar, or with the telescope, you can completely do the procedure. The same thing here, also simulating the septum. But these are all flimsy, these adhesions, and this can present with infertility. This can present with the recurrent pregnancy loss for that. And here you just have a blunt dissection and find out, and otherwise you have to use the Caesar for that and just break it. A Caesar, it's very simple to do it without also with the hysteroscope. In this case, the whole with the telescope itself, with the hysteroscope, see then it is gradually, it is absolutely whole band is underlied and whole cavity is returning to normal. So this is one of the procedures where in complete synechia, it's a very, very rewarding result for that. And the seizure can also be used for that. But don't use the cautery. Cautery is usually not necessary for that unless it's a very tough fibrous tissue which is not being lysed with the conventional procedures for that. And after the end of the procedure, you can find a very good cavity after forming. Still one band is left behind for that. And that is the procedure where you get a very, very good rewarding results after the procedure for that. And this synechia, if it's a complete synechia, I think it's a hell of a job, and you should do with the laparoscopic guidance for that. Now, at the end of the procedure, you can see a very beautiful cavity with that. You even the splint is not necessary, or the IUCD is not necessary. Neither the estrogen is not necessary for that, and you can find clearly whole of the cavity forming a normal thing for that. Now, coming to the polyps, the nature of the polyp, I say that yes, the nature of the polyp varies, the site varies, the number varies, and it must be a hormonal correlation. As we say that in multiple endometrial polyps is mainly for estrogen, hyperestrogenic, and therefore whether to intervene or non-intervene, there is a question. If there is a multiple endometrial polyp, it doesn't need any intervention for that. But a solitary polyp needs an intervention, and big solitary polyp could be one cause of infertility as a space-occupying lesion as well as recurrent pregnancy loss. This again, I have already told that hysteroscopic. This is again one of the osteal polyp, where you find the polyp is arising from the osteum, and along with that there is a septum. We have done a septoplasty, and then at the same sitting, just with the grasper, we just remove it with that and dot it. Now this again at the same polyp, where it needs a treatment modality because it is a size about 2.2 to 3 centimeter, occupying the whole of the cavity, and this could be a prominent cause for the infertility or pregnancy loss. So you can see the pedicle where it is arising. The tissue is originating from the right upper wall, interior wall, and after that you can see that it is being demolished with that with the grasping forceps, or you can use the cautery hysteroscopic polypectomy like this. So this is case you go and with the same operating resectoscope, with again a bipolar resectoscope, we commonly use it, and you see that all around in the base we are just using that, and then we come again from the usually from the top to bottom, from piece by piece we can do the total resection of the endometrial polyp. And remember that this is the case where we have almost the base we have identified, and just you can see the difference between that. After the chunk of the tissues is being removed, then you can say that yes, it's a polyp, it's not a muscular thing, it's a very sharp, and you can find the gland openings also there after removal for that. And this is how you do it, and the whole polyp can be resected under vision by the hysteroscopic resectoscope. And the procedure is not very difficult procedure. Only thing is that either you can do it with the unipolar or with the bipolar. But this is the difference, characteristic visual difference, impression of polyp rather than the myoma for that. Myoma, you can find a muscle in between, and it's very important for that. Now, after you can see the base is completely removed, and now is that whole of the polyp, you can just remove it. Automatically it will come back piece by piece, but you are very sure that I have removed without damaging the endometrium. That is very important for that, and you can send it for the histopathological examination for that. Again, this is another case where if polyp, you can find the polyp, and this polyp is arising from the posterior wall and right lateral wall, and you can see the base, and whole of the cavity can be better visualized with that. This classically, it cannot be, the appearance itself tells that yes, it's a pale and it's not very vascular, and it is not a submucous myoma. Now the same resectoscope, you can use it and deliver. So these are the cases where this could be a cause of infertility because it's a space occupying lesion, and therefore this has to be resected for that. And believe me, I have found, I'm very happy that these are the cases which are not nowadays with the sonography, with the new resolution sonography, this is being diagnosed. Many times this polyp is confused with the thick endometrium. Endometrium is thickened, the radiologist give the impression, but this is endoscopically, hysteroscopically, the diagnosis is more accurate, and the resection as commonly done with the bipolar resectoscope, with the normal saline, you can completely resect it. And you can see these are the base where there is this little blood blood vessels. So therefore, I wanted to coagulate that in the base first, and then piece by piece you have to remove it and send it for histopathological examination for that. And at the end of the procedure, believe me, you don't resect all of the endometrium. Damage could not be there, so that you go in the base and find out whatever limit, whatever desired limit is there. You can find out now. It's completely clear. Whole of the base is, you can visualize that, and therefore this completes the procedure of polypectomy. Now coming to the myoma, again the procedure is same, and myoma, treat or don't treat by endoscopy, either by hysteroscopy or by laparoscopy. But the myoma which is encroaching on the cavity, a FIGO grade 0, grade 1, grade 2, or maximum grade 3 can be resected, and these are the causes of infertility. So basically the principle is that the myoma which is just encroaching the cavity, even if it's not a 0 or 1, even in the 2, if it is the cavity, you can find that there is a bulge. I think these are the causes of infertility or recurrent abortion, and that needs treatment. And the ideal treatment is a hysteroscopic resection. If it is more than 5, 6, these are the cases, and the size is more, they are indicated for laparoscopic myomectomy. But this is a procedure which is very, very easy and can be solved, and you have the same classical precaution of a fluid deficit using the either of these bipolar or unipolar, depending on the equipment you have available for that. The location, size, and number can be planned by earlier sonography. Pre-op preparations is not very much essential, excepting the misoprostol. You give a misoprostol before all therapeutic procedure, not proper diagnostic procedure, and then you can clearly do it. But the bigger size myoma, you can do it with in the staged manner for that, not in the single sitting. And these are the cases where these smaller myomas can be very well resected with the bipolar resectoscope. The technique is very, very important. I've already enumerated during the myomectomy or during the hysteroscopic myomectomy in my previous episodes. But again, I want to emphasize that these are all fertility promoting surgery, and this try to preserve the healthy endometrium, and therefore, as far as possible, you are using the current, don't damage the endometrium extensively. And therefore, you select, if there are 2 myomas, anterior and posterior, or multiple myoma, don't do it in a single sitting. Either there could be endometrial damage, or there could be iatrogenic synechia, postoperative synechia, opposing surface for that. But for that also, you can do a check hysteroscopy, and then the second sitting, you can complete the procedure for that. So there are limitations also, and the results are really rewarding for that. So this is again a case of submucous myoma. It's a grade 1 myoma. You first identify, visualize the hysteroscopic cavity, the ostium, and then go for the myomectomy for that. Same procedure as I've already told, and the same laparoscopy can demonstrate the whole view of the uterus and the tubes, ovaries, and then you can start the procedure of the myomectomy, as I've already shown this. So these are the cases where hysteroscopic myomectomy is definitely placed. Remember, the rule of thumb is that if the myoma is just seen in the cavity, it is the bulging in the cavity, I think the cavity is encroached, then there is a treatment. Otherwise, if the cavity is not encroached, don't touch it, and there is no place on that, unless the size is much more, and laparoscopy has to be resorted for that. Is again a myoma. The other method is a saver system. I'm not using the resectoscope here in hysteroscopic resectoscope. This starts as a saver system. This is a morcellator where 180 degrees to and fro movement of these jaws will be there, and this whole myoma will be shriveled into just sands, and suction will be there simultaneously, so that the whole myoma at the end of the procedure is absolutely without a cautery. The advantage is that the endometrium is not damaged, but the demerits is that very large myoma cannot be done with the saver system. It takes a long time is more, but medium-sized myoma of about 3 centimeters can be very well tackled with the saver system. There are a lot of advantages because the current is not there, and the endometrium is not very much damaged here. And it's very simple. Just touch it and just start it, and it will go further. Now, coming to this another area where septum. Now, when we come as a septum, first ask yourself whether the septum is a cause of infertility. I think the fertility promoting surgery. I think all septum are not cause of infertility. The septum is a cause of pregnancy loss, recurrent pregnancy loss. But in a case of infertility, if you have done treatment, if you find on diagnosis that there is a septum, don't do the septoplasty immediately first, unless it's a big septum, complete septum, and you investigate another line, you treat it, and if there is a failure of that, at last you can do that. Presuming only thing is that, could it be that implantation could be on the fibrous septum, and there could be early pregnancy loss, which you are not able to diagnose. So therefore, septum indication of septoplasty in infertility is there, presuming that if you presume that yes, that could be implanted on the fibrous septum, number one. Number two, if you are going for ART procedures and IVF procedures, if there is a septum, I think a diagnostic, I always believe that cavity evaluation should be done prior to IVF, because if there is a septum, it's a very easy procedure. You can correct it and then go for IVF, rather than subjecting for IVF, achieving the pregnancy, and then a loss for that. So these are the cases where ART procedure, IVF procedures, you do it, and this septum. So all septum doesn't require any treatment. This is a septum with arcuate uterus. You find a clear cut, the Mullerian fusion line can be seen very well for that. And there we find an arcuate uterus, very small. It doesn't affect pregnancy. So arcuate uterus is not a cause for surgical intervention. You can see, do the test, and you leave it as such, neither for infertility nor for pregnancy loss. So again, this is another case where we find that yes, it's a long septum. You can find the septum is up to about the middle part of the cervical canal. So here we find a broad fundus. This is again corroborating with that. Testing for infertility. The dyes are there. The other things is there. Now it's a long years of infertility. 7 years of infertility. We find a lot of treatment is there. So now I find that I should cut this. That it could be one of the cause of infertility, and we must treat it for that. So therefore, this septoplasty I've already told about the earlier also in my episodes on hysteroscopic procedure, and as well as the Mullerian abnormality. I've already enumerated and emphasized all these. But this is again a procedure where it is a rewarding results for that. Again, this is a case where you find just demonstrating all these, repeating all these. Again, this could be, again, you can find the septum at a low level. The lower end of the septum is occupying a sheath in the upper part of the cervix. So then this is a complete septum, needs a resection for that, so that infertility and recurrent pregnancy loss, both, it could be one of the causes for that. And therefore, this is a rewarding surgery for hysteroscopy for that. These are again the septum, which is a complete septum. It is at the level of the external os, and just demonstrating this septum. And this is one of the cornu, one of the horn where the ostium is visualized, and the other horns also you just retract, and this is visible. And then in the center of that, you can find out that yes, this is the septum, fibrous septum, where you identify in the middle of the septum, you just apply the current and then go through that, and the whole cavity is unified, and the whole cavity is well formed for that, for implantation as well as for continuation of the pregnancy for that. This again, therefore the septum, the length is important, the breadth is important, whether the thickness is important. This is a septum where we find typically this is a septum about 1/3 of the cavity, occupying the 1/3 of the cavity, and these are the cases where they usually present with pregnancy loss. But these are not a primary cause, a primary treatment if you find that. But if you do some infertility investigations and treat it, and failure of this, you can resort this, because another reason is that even if you do that and pregnancy occurs, there could be loss. So therefore, this is one of the again indication for septum resection for that. Now, this is I demonstrated this on particularly on the power. you are using the energy. This is a case where the septum is very thin septum. If it is a thin septum, this can be amenable by many people use the seizure for that. I don't use the seizure in the case of thick septum, but a thin septum like this can be tackled with the seizure for that. So the tips and tricks are there. With the either you can use the electrosurgical device, or you can use this by the seizure. This can be done by seizure. But there are some of the septum which appears thin at the distal part. As you go down, go up and up, the thickness is a broader septum which is there for that. So both methods can be used for that. Again, this is a thin septum where this is one ostium, one horn we can go for that, and then you can go for the other horn, and you can beautifully find out the thin septum. And this particular thing is absolutely necessary to treat it for that. This is an atypical symptom. I found some of the atypical symptoms for that. Patient presenting with severe dysmenorrhea, and on sonography we find a anechoic area inside the uterus, and therefore on hysteroscopy we don't find one ostium is found and the other ostium is not found. On laparoscopy we find yes, the left tube and ovary is normal, the right ovary and tube there are some adhesions inside for that, and therefore we go for a hysteroscopy, and the hysteroscopy we find that there is a bulge on one side, and the bulge on one side signifies that there could be hemihematometra. One side is that is non-communicating, and here hysteroscopic procedure we just do it and just find out deeper, go and find out whether the where is the canal where we find the obstruction, and as we go down deeper we find that on the one side particularly still it is nothing is visible, but we're waiting for the hole to come, and then we are happy that we can control for that. Now these are the cases where very atypical case of Mullerian anomaly where the non-communicating and there is a obstruction, there is a functioning horn is there, and as if it is going for a severe pain is because of the obstruction on the one side for that. So, but very carefully you go for that, and at last we find that yes, there is a the opening is found, and we go and negotiate with that, and the whole of the cavity can be reconstituted as we see in progress for that. And here you find now you can find out that the clot, the old blood is coming, and that is the hole for that. And then as if it is a septum, after that you can find the ostium on that particular side. You enlarge it when you find it, and then the whole of the accumulated blood on the particular aspect, non-communicating horn, and it's not communicating outside to the vagina also. Now after that you can find, and this appears that whole of the septum, the whole of the non-communicating septum is just giving an incision, and the unification is being done for that. Now next step is the proximal tubal block. The nature of the block is important for that, and remember number of segmental block, whether it's a proximal tubal block, when the tubal factors of infertility, whether the tubal factors of infertility, proximal tubal block or a distal tubal block or a mid-segment tubal block or a multi-segment tubal block. So these are important, and underlying pathology is important. Normally if it is a fibrotic block by the adhesions, classically the chlamydia or any microorganic organism, there is an adhesion for that. It is very difficult to cannulate with that. But normally the cannulation which you go for a proximal tubal block is mainly because of the inspissated mucus. And here we find that yes, you negotiate and a selective cannulation is being done, and you can find it clearly the whole the proximal tubal block is here. This is the scene where we again negotiate with the other ostium with the cannulation catheter, and this cannulation catheter has 3 parts. I will just demonstrate all these and just introduce the whole thing can be cannulated. There we didn't get a dye by selective cannulation, so therefore whole Teflon wire is being introduced, and that is the process where you do cannulation. And this is successful only when there is a inspissated mucus. It's not a fibrotic thing. So therefore fallopian tube cannulation, tubal factor of infertility is about 25 to 30%, out of which 1/4 is a proximal tubal occlusion for that. And these occlusion can be rewarding surgery by inspissated mucus. The pathological basis is tubal obstruction and tubal occlusion. And therefore, it could be inflammatory, it could be mechanical, it could be congenital for that. And the diagnostic criteria is either HSG or a hysteroscopy. The hysteroscopy and HSG will give the proximal tubal block. But remember, the technique is also important, in which you go for the HSG cannula or Wilkinson cannula. If the tip touches the muscle, I think you are not gone to the proper cavity, then automatically the block will be there. So these are all false positive findings. Same thing happens with the laparoscopic chromoperturbation also. So this is very, very important to carefully see that you are going to the proper direction inside the cavity for that. So the evolution of the procedure, either earlier we are going for a macrosurgical procedure, then we are going for a microsurgical open procedure by just having a reamer in the convolute and joining to the cavity for that with the 6-0 proline or 6-0 Weichel for that. Now minimal invasive procedures have adopted for that, and the methods of cannulation either by fluoroscopy guide, wire catheterization system, or a transcervical balloon tuboplasty, sonography guide, or hysteroscopy. Out of all these, the most rewarding is the hysteroscopy guide. And hysteroscopy proximal tubal cannulation, when we talk, hysteroscopy was searching for indications, and indications was in search of hysteroscopist now. So therefore, gone are the time when we are searching for indications. Now the indications are searching for hysteroscopist. This is the sequence where the intramural portion of the tube is sinusoidal and difficult to catheterize. And that is the point where isthmic part, there is a constriction. In the interstitial isthmic part, there is a constriction. There, the inspissated mucus is forming a block, and therefore, this is by really the rewards are very good by doing a cannulation. You cannot cannulate a fibrotic block for that, and that's very sure for that. These are some of the examples for that. So it's a viable alternative to IVF, and therefore when I talked about the debate between IVF and the fertility promoting procedure, once it is done, I have seen many cases who have done IVF or failed from IVF, just a hysteroscopic cannulation. I'm very happy with the procedure for that because it's a minimal invasion with maximum benefits. It needs expertise and the future, but ultimately, if the tube internal pathology is not there, the physiological things are maintained, internal thing, I think patency and potency both are important. We can make it patent, but we cannot make it potent. So the underlying pathology is important for the success of the pregnancy for that. This is what is called the cannulation catheter. Earlier, we were using the novice cannula and it's very costly. Now, India Genius is indigenous cannula. We use it for that. Earlier, we were using the urologist ureteric catheter also. That is very thick, but this is very good. That is a 3 pieces. And one, you go negotiate with the stellate inside and then find out and just find out. And this is the stellate which is there. And you negotiate with that, with the stellate, then the Teflon where you use it, and that is not going to injure. And therefore, this is one of the cases where we find, these are the cases the ostia is not very clear. We find that there is a layer which is there. This is usually in a case of proximal tubal block. You negotiate with that and the stellate, remove the stellate, and then this is the inner Teflon where you find out. And confirm it by laparoscopy. On laparoscopy, you just confirm that you can cannulate the proximal part. Mainly, if a proximal part is cannulated, if the rest of the tube is normal, you do a chromoperturbation and this is found. Otherwise, you can do the selective cannulation on one of the tubes, and then you can find that the cannulation is completed for that. Now, after that procedure, when we say that the laparoscopy guidance, you can find that on vision, you can find that the cannula is coming out. And the Teflon wire is coming out and we're in a proper place for that. And there is a chance that it could extravasation of the dye could be there if you're going for a wrong direction for that. So this is one aspect where when the proximal tubal is there, there is absolutely through and through is not necessary for that. There's enough for that. And then you just test it by the dye and the dye will be coming for that. So this is how the cannulation can give a rewarding results for that. And apply the dye, you can find it clearly the dye is coming and this cannulation is successful for that. Do it on the opposite side also. This is another case which I have faced it. Even I'm using it's not using the ureteric catheter, I'm using the same cannula, the India Genius indigenous cannula, and our Bimal Shah PB, I brought it with a very, very nominal price and just negotiate with that. This is the initial thing. And then when I introduced the Teflon catheter, you can see you straighten the tube, and the Teflon catheter, when I introduced it, you can see that now it has seen that it is coming out. It has a perforation is there. I was very much unhappy on this, but again, I withdraw that, and again try to negotiate on this and straighten it, withdraw it, and again try to negotiate, and then it went it in a normal direction, and then it come out, and ultimately the whole tube is cannulated with that, and then you can see that the cannula, the Teflonware is coming outside, and that same part, then I tested, I find that yes, there could be a free spill for that. Even if there is a small puncture with the cannulation, it is not going to hamper. Just for the sake of testing, I'm just holding it, and the dye is clear for that. So this is one aspect. The failure can occur, but normally, and this is one of the cases where. Now this is another case where the cannulation I have done it, and there are cases where the assistant must be very steady, and the cannulation have an expertise that if the steadiness is there. This is another case where you find that these are the cases where is it cannulation possible? These are classical example of chlamydia, the perihepatic adhesions, and you find the adhesions from the adhesions, the nature of the tube is important for that, and these are the cases where the chlamydia, you don't go for cannulation, it's not going to help you anyway, neither in laparoscopic procedure. These are ideally, you diagnose that these are the cases, only the IVF can be of help to that. So these are the cases, it's not suitable for the cannulation for that. This is again a case where you find that there is an extravasation on the left side, but here on the right side you find a mid segment. The ampler region, there is a obstruction, a multi-segment block, and all that. These are the cases where it's not amenable for cannulation for that. Now coming to the foreign body, the leftover cannula tip is one. When earlier cannulation, the suction evacuation was being done, I found many cases of cannula being tip is left over, but osteospecules. The patient presenting with secondary infertility, sonography finds that there is a hyperechoic lesion, and we do not know what is the hyperechoic lesion. When you put a scope, then you can find the osteospecules, or there is a forgotten IUCD. They have taken an IUCD, but it's a forgotten, and they present with the secondary infertility, or a forgotten stent. When they're doing a microsurgical procedure, we're using the stent. Nowadays, the question doesn't arise. So these are the cases where I've seen in the cases of secondary infertility, sonography gives an idea that there is a hyperechoic area inside the cavity, but clearly these are cases of previous abortions, and previous abortions either undisclosed or known abortions, and these are the cases where the bony spicules inside the cavity will behave as an intrauterine contraceptive device. So here there are multiple bony spicules. Under hysteroscopy guidance, you can remove it, and hysteroscopy guidance, you just with grasper, you hold this, and under vision, you can remove this, and this could be a very important thing and rewarding surgery for that. Now you catch hold of this particular thing and remove that, and that is very rewarding. And remember that this is the grasper, hysteroscopic grasper. You just piece by piece, just drag it, and under vision, you can completely do the job for that. These are again bony spicules, the same thing. Another case where you find a number of cases. It is not it's very rare, it's common. We find these are the cases, but they present with the secondary infertility, and sonography can give a suspicion of that, and then it's very easy that under vision you can do that. So this is one of the foreign body of bony spicules giving rise to the fertility. Is the fertility promoting surgery could be there, and this is how you do that. This is again a forgotten IUCD. The present, she has taken IUCD, but it's a forgotten, and sonography demonstrates that again there is a hyperechoic. And on speculum examination, I then find the tail. The tail has been inside. The tail has gone inside the cavity. So therefore, it is not being seen. And this is one how you remove that. Another area is the cavity augmentation. If there is a small cavity or irregular cavity, so hysteroscopically you augment for fertility. It is a Mullerian anomaly like a unicornate uterus is one of the example. If it is a T-shaped uterus, you just do a lateral metroplasty, or if it is a small uterus, you make it more bigger, you can have a lateral metroplasty for that. Or in a tubular cavity, previous surgery of myomectomy, or in any tubular cavity, you go for a lateral metroplasty. There are a lot of controversies rather than consensus for that also. Before IVF procedures, many fertility specialists also advise for that. And this is how we do a lateral metroplasty in a tubular cavity. It's very easy. It's not a very difficult procedure. But in my experience, I didn't find any rewarding results for that. And this is a unicornate uterus with a rudimentary horn on this side. And with the, again, power source is required. With the hysteroscopic, this is how you do it at the current and right angle. Just on the lateral aspect, you just make a incision, make a line groove, and that groove is going to be enlarged on both the sides, and that can give rise to a augmentation of the cavity. This is but how deep you go it depends, because the lateral part, the uterine is going to be involved. So don't go, it's just a clinical approximation of how deep you can go it, and the thickness of the muscle on the lateral aspect you go it. And of course, the 5 millimeter is absolutely mandatory, and it's good. Don't go more than that. And this can give rise to a hypothetical cavity augmentation and pregnancy result for that also, but I have not found any significant thing for that. Now coming to the laparoscopic fertility promoting surgery, these are some of the areas where I will just touch it: ovarian drilling, ovarian tumors, endometriosis, myoma, tubal factors, and pelvic adhesions. Now, surgical ovulations, options for ovulation induction, classically the LOD, the Steen and Leventhal concept, we have transport for the endoscopic view. And 1935, Steen and Leventhal found out bilateral wedge section of the ovaries, and the endoscopic advances replicating the procedure with minimal invasion and maximum benefits. So these are the candidates for LOD. PCOM, the failure of medical management. When there is a failure of medical management, is there. Earlier it was told that gonadotropin, you give your oral ovulations, then gonadotropin, if it fails, then now CC resistant has been accepted. The first line management is CC or letrozole resistant cases. You can go for these vis-a-vis gonadotropin and LOD. There could be a good result for that. But these are the first indication. Non-responders. Again, when there's an increased trauma, when this trauma is more, I think these are the cases where, and there's just sclerosistic ovaries. On diagnosis, when you find the typical sclerosistic appearance of the ovaries will be there. And last is the lean PCOD. The results are much more better if they are very obese, more than 35 BMI, or the LH less than 10. These are all results are very, very less. And the third is more than 3 years of infertility. So less than 3 years, increased LH more than 10, lean PCOD, and increased trauma. These are the candidates for laparoscopic ovarian drilling. And the techniques, either you can do a bipolar, unipolar, or laser. There is no difference between a laser and unipolar, and we find that the number, depth, watt, and timing varies. Starting from multiple holes, we have come to rule of four holes. Because the major thing is that if you find the holes are more, you're damaging the ovary. If the current are more, you're damaging the ovary and giving rise to a premature ovarian failure. And second important is a peri-ovarian adhesions. These are the two main demerits of the ovarian drilling. So the young endoscopic surgeon has an irresistible desire to make holes and holes in the ovaries when they found a beautiful, smooth surfaced, pearly white ovaries. Try to refrain. I always say there must be some indications and some methodology for which don't make holes and holes for that. And spontaneous conception are the results, facilitating non-responders, which non-responders could be responders, and there are variable results. It decreases the method with which decrease LH, AMH, and androgens for that. The two main complications are premature ovarian insufficiency and pelvic adhesion. Be cautious about it and do the procedure in a better. So you're balancing the risk and benefit. Variable result, selection of patient profile is important, and don't have an aggressive policy, have a non-aggressive policy for that. And therefore, These are the cases where you must be very, very meticulous in doing the laparoscopic ovarian drilling for that. The two, you catch hold of the ovary with the level of the ovarian ligament, and then in the antimesenteric border, you make hole with the high frequency needle. You make a hole, and the rule of 4 is there, and the 4 second, 40 watts, and 4 numbers for that. The number of holes, I think, it depends on the number of holes will depend on the volume of the ovary also. You can go for more number of holes in a case where the volume of the ovary is more for that. Now, second is endometriosis. The enigma for endoscopist and infertility specialist is endometriosis. The theme of therapy of endometriosis is relief of symptomatology, arrest of progress of the disease, promotion of fertility. And the medical versus surgical technique are there. Laparoscopy has become a gold standard in diagnostic as well as therapeutic. And the technique are multiple. And the right technique can give rise to a good result for that with minimizing the complications. The fulguration or cystectomy, either of the cystectomy or fulguration, I think the size is important. The fulguration, if you do a fulguration, what will be the demerits? The demerits is there, the recurrence rate will be much more. If you do a cystectomy, recurrence will be less, but there is a chance that you are removing the healthy ovarian tissue, so that the premature ovarian failure could be there for that. But remember, depending on the sign, less than 2 centimeter, always we do for a fulguration, or the surface lesions, we do for a fulguration. Otherwise, the cystectomy is the better benefit for that, to prevent recurrence and to have a good result for that. Electrosurgical device versus laser. Earlier, laser gives the precision therapy and not damaging the healthy ovary, but electrosurgical device also with the bipolar, with the careful selection of the fulguration sites, you can, I think, equivalent result for the laser. Single versus stage procedure. The stage procedure of endometriosis by Donnage, 3-stage procedure, now it's not feasible, and therefore the single procedure, the primary method, primary thing is the best surgery for endometriosis for that. But the pre-op, and this is the pinnacle where I say that let me observe an endoscopic surgeon doing a laparoscopic surgery for endometriosis, a conservative fertility promoting surgery, then I will rate the endoscopic rating of that particular surgeon. Not by doing a laparoscopic radical, not by doing a TLH, but this is very, very important. The pre-op and post-op adjunctive therapy of general analog, I can do it. And results, absolutely variable for that. We can't say that by doing that, you can get 100%. But remember that the first window of opportunity is 6 months to 1 year. From that, during the time of surgery, don't delay it, and always encourage procedure, either stimulation for that or the IUI procedure for that. This the size matters. The ovarian endometriosis, particularly if the uterus is normal, there's no adenomyosis, only ovarian is there. Even large ovarian, large endometriosis could be much better for that. A very important part is that you not only do a cystectomy, you do a good adhesiolysis, salpingo-ovarialysis, restoration of the normal anatomy, and then doing a cystectomy. Now, the rectosigmoid here, everything is pasted, both the ovaries, and the rectosigmoid is adherent completely to the uterus, posterior surface of the uterus, with extensive adhesions for that. So remember, and the trick is to identify the cyst wall, and the cyst wall, you catch hold of that, go through the proper cleavage so that you are not damaging the proper and the healthy ovarian tissue. Don't take much of the healthy ovarian tissue. With the traction and counter traction, you can clearly find out that these are the healthy ovarian tissue. You must preserve it and remove the cyst wall for that. The very important that it needs a good meticulous surgical technique here. This is almost a grade 3, grade 4 endometriosis, and you see that these are the cases where initial period is very, very important. That initially the identification of the cleavage is important. Once you got the cleavage, go through that, and now everything can be very easy for that. And the whole of the cyst, even if the large cyst, also can be very well delineated and very well enucleated with this if you go for a proper. Remember, a good vision is important. Normally, I always say that a 3D laparoscopy is much better than the 2D, and 3D laparoscopy gives a quality of life for that. And before the vascularity also, you can increase to diminish the vascularity. You can just inject the vasopressin on the posterior surface of the uterus, and then you can give a pre-op GnRH analog and just keep the healthy ovarian tissue. If once you find that this is the normal cleavage, there is no doubt that you can do a good job for that. So these are the cases where endometriosis, apart from the cystectomy, important is the adesolysis, tube ovarian relationship, and don't use much of current for that. If you are going to the proper cleavage, the bleeding will be less, and just use less current for that. And then as early as possible, you encourage pregnancy. So laparoscopy in endometriosis is really a boon. And this is again another case where you find how the adhesions for that. Tube ovarian adhesions are there. You just do a adesolysis, complete adesolysis along with the ovarian cystectomy. The right ovary, there is a chocolate cyst, but you find that whole thing, both the ovaries and the POD are full with jellies and adhesions. You do a good adesolysis and then do this procedure of maintaining the principles of a tube ovarian relationship maintenance and cystectomy for that. Again, these are the cases where there is a minimal endometriosis. The ovary is just, right ovary is just adherent to the ovarian fossa with the jelly, and in the uterosacral there is a endometriotic season. These are all minimal endometriosis. Earlier it was told that minimal endometriosis, you treat or don't treat, fertility results are all same. But now we find that yes, the same sitting in a diagnostic, if you find a minimal endometriosis, just fulgurate and just do a good adesolysis, salpingo-lysis for the restoration of the anatomy. The result will be much more better. More important is that the prognosis, the recurrence or the arrest of the disease is there. You don't go for that. This is one important observation which I find. If there is a unilateral lesion, either a chocolate cyst or salpinx or a teomas, where the other ovary and tuber is absolutely normal, and more so particularly they present with second infertility, and there is one issue is there. I recommend always unilateral adnexectomy. Removal of the ovary and tube both rather than only the cystectomy. The persistence of the pain will be there, and therefore if you remove the unilateral cystectomy, adnexectomy, you do it, I think the pain will be relieved and fertility will be augmented for that. And this is my observation for that. And therefore, these are endometric lesion, how it is adherent to the uterosacral and the posterior surface of the uterus. You go to the proper cleavage and just lift it and then find a good cleavage for that. And the same. So that is important. I give an importance to the adesolysis and least use of cautery. My dissector is always the suction irrigation cannula, and that is a very good thing. And remember that these results are much better if you do that. So remember, the size of endometriosis is not related to the infertility. Even the small endometriosis, the cause of infertility, that could be the adhesions, adesolysis. If you do not do it, do not have a good tube-ovarian relationship, the pregnancy is not going to happen. And therefore, the laparoscopy has definitely a place. It is not that it has no place for that. It is a very important place, particularly not only to diagnose endometriosis, but it is a gold standard in diagnosis and therapy, particularly for infertility promotion. These are all minimal endometriosis, Allen-Master lesion. It's a gap in the peritoneum, apart from some the pinkish, black spots or white spots, endometric lesion, surface lesions. You just coagulate, don't leave it as such. So now coming to the myoma uterus, the rational decision for myomectomy should be done, treat or don't treat, the size, number, location, the technique, the suture, controversy versus consensus. I've already told while dealing with the hysteroscopy myomectomy. In case of fertility promoting surgery, or when the myoma is just encroaching the cavity, there is an indication. So 0, 1, and 2 are the indications for that. Then the thing is come. Subserous fibroid is not the cause of infertility. That is very important. Unless it's too big, predominantly manifesting with the symptoms of pressure symptoms, you operate there. Otherwise, the subserous myoma are not at all a cause of infertility. But the intramural myoma, particularly the larger than 5 centimeters, even if it is a 5, 6 grade, FIGO grade, 4, 5, 6, and the size is more, you may not do it in the first sitting. you do investigate, promote fertility for some other, because we have seen pregnancy with myoma in many of the cases. And if it is not there, then there is a place for laparoscopic myomectomy for that. So therefore, these are the cases where treat or don't treat. And you remember that these are the cases where you find that this is a cervical myoma, posterior cervical myoma, this is anterior cervical myoma, subserous myoma, where the cavity cavity evaluation by hysteroscopy, if it is normal, don't touch it. It is not necessary unless it's very big for that. So you have to decide where not to do myomectomy for that. These are the cases where the 7 years infertility with a fundal myoma, anterior myoma of about 10 centimeter diameter. And apart from the infertility, she's having a menorrhagic cycle, and although the cavity is normal, we have given ample scope of opportunity for fertility promotion, but it is not there. Then the laparoscopic myomectomy is there. I've already in my previous episodes of myomectomy have demonstrated. Just to recapitulate and repeat the procedure, this is how the vasopressin has been given. After the vasopressin, you just give with the unipolar incision with the unipolar and find out the place. You go directly to the level of the myoma and identify the capsule where, and you overcut rather than the undercut to define that where is the space. Now you can find I have overcut it, and I could find that this is a myoma which can be easily obtained for that. And catch hold with that, and this is a myoma separator, and with the myoma separator, you just separate the myoma, and the whole myoma can be nucleated with the really in the good space. So if you are going through the proper cleavage line, the bleeding will be less, and you can be very successful for that. And then the next step will come, the myoma is completely nucleated, and next step is suturing. Now for the suturing, the barbed suture has a renovation, has a revolution in the big intramural myoma for that. And this could be very well earlier, before the barb, they repeated with the Vicryl, it took a long time, and the single layer, many people use it, the double layer, you can give it, but it takes a longer time for that and very inconvenient. So in a large myoma, intramural myoma, to obliterate the dead spaces, you require multiple layer closure. At least 2 to 3 layers of closure is important, as you do in a classical conventional thing, and same thing you do, but go through the proper cleavage so that you can be very assured that it is not there. There's another myoma on the anterior aspect, and you just remove it on the anterior aspect of that, and so that you don't leave the only myoma there. And after just enucleation of that myoma with the same method, with the traction, counter traction, and going through the proper cleavage of the finding out the cleavage with the capsule, and this is called a capsule, where the whole thing myoma can be. There is a bilobed myoma here, and already 3 myomas are there, and we have removed the first myoma, and then subsequently these are the cases where completely myomectomy in an avascular manner, although you have given the vasopressin, but still if you're not going to the proper cleavage, the bleeding will be more, even if the vasopressin has been given. So this is the cleavage where you give it and then do a suture and completely close it with the procedure, and so that the dead space is not there, and you are having a good closure, not only for immediate postoperative avoiding problem, but for subsequent pregnancy, for the scar integrity, you suture in such a manner that the scar will be much better in the subsequent pregnancy if it is there. And this is the barbed suture which I'm using it. You go for a layered suture, and this really, it needs a lot of training, expertise for that also. And normally the younger generation are very good in suturing once they have a training for that. But this barbed suture has helped us really in that, in the big, in a multiple layer closure. And therefore, after the end of the procedure, you can find the undermining thing, and baseball suture can be usually in the last layer. You can have a baseball suture so that the barbed suture is not visible outside for presumed adhesions there for that. So these are the cases where the myomectomy, laparoscopic myomectomy, I've already told. At the end of the procedure, you can find that yes, just stretch it and the whole thing. You cannot find the myoma, the barbed suture outside, and this is the end of the procedure for that. The results are very, very alluring for that. Now, this is again adenomyoma. Adenomyoma, the diffuse adenomyoma is not amenable for surgical method, but localized adenomyoma is amenable for the surgical method. These have two main advantages. One is the pain symptoms will be relieved, number one. Second is that the fertility will be promotion of the fertility or augmentation of the fertility will be there. The same thing as you do in a myoma, you do it. Debulking, it's a type of debulking procedure. But remember that the difficulty lies in suturing here. So cut in such a manner so that the edge to edge can come out in a proper position for that. So the incision should be made in such a manner from front to back. It's like a cleavage is like a concave area, and so that the end of the procedure the suture can be very well made for that. So this is how you do a adenomyomectomy and finish the procedure for that. So main thing is that the bulk of the tissues we removed it, and be very careful that you are not going through the cavity. And at the end of the procedure, again the same barbed suture can be used, but the suturing edge to edge is very important in comparison to the myoma. It is really tricky, and the procedure is that you have to undermine the edges so that the front edge will come. Otherwise, if you do in the same plane, it cannot be opposed in a proper position for that. And then you can go with the same barbed suture. At the end of the procedure, you can find that yes, I've done a good job for that. So these are the adenomyoma, localized adenomyoma. The technique is something different than the myoma, but remember the advantage of relief of the pain as well as promotion of the fertility. I have observed that this is good. And these are the cases where is only adenomyoma, the tubes and ovaries are absolutely normal. So these we get a good benefit out of it for that. Now, tubal surgery, in a laparoscopic tubal surgery, in mainly in distal tubal block, in peritubal adhesions, in hydrosalpinx, and the procedure like salpingolysis, salpingovarolysis, fimbriolysis, fimbrioplasty, neosalpingostomy, and tubal recanalization. The results, and this depends on your quality of surgery and place of salpingoscopy or falloposcopy. We are not doing it. I don't have any experience on that, so that I'm skipping that. So this is a procedure where we find that the distal tubal block. The tubal block normally could be proximal, which can be best dealt with by the hysteroscopy, and the distal tubal block where it is dealt with the neosalpingostomy. But remember, another thing, important thing is that if there is a multi-segment block, if there is a peritubal adhesions, the internal damage is less, so that the results of pregnancy is much more. As we see in a case where in an endometriosis, the internal tubes are always remaining free, but in infective variety like this, there is a completely closed, and you find that the tubes is clubbed, only the distal fimbria is there, but this side, one of the tube is there, one of the tube and ovary is normal. But here in this case, the left side there is a proximal tubal block, and the right side there is a distal tubal block. The right side distal tubal block, you can find that on the dye, you can bulging that totally the total fimbria, the only fimbrial tissue are there, but there is a terminal hydrosalpinx. So here we do not find anything, but there is a proximal tubal block. So this particular case, I'm showing you purposefully that on the right side, I will do a terminal neosalpingostomy. That means particularly you make a hole, make a incision there, either with the seizure or with the unipolar. It's just a fimbrial end, and you can find the pit. This is the pit which can found it. And we just go through that, either make an opening with that. We do not, earlier we are being told that yes, make a crisscross opening and doing a cup salpingostomy. In laparoscopic procedure, the main procedure which you do with a modified intersusception technique, so that you make a hole, and hole should not be very large, otherwise it will be not possible to bring out the internal thing and evert it. So modified intersusception technique, you evert it, and remember that this is a procedure where you make a small opening here. If you make a big opening, very big opening, again the neosalpingostomy is not possible for that. So these are the cases where the distal tubal block is important. But main thing again, I can say that even if the patency is there, we do not know what is the interior, the cilia or the interior of the tube there. So although this outside patency can be maintained here, but it is not possible that. So either you can give a cut, or I'm here giving a unipolar cut and the cutting current and going through that, and I will reach the lumen. I think this is the lumen which I reach it and just step it, and that is, don't make a much more bigger hole for that. And with that, you bring the interior outside, and this is called a modified interception technique. So this how then you catch hold of that and hold it, and then with that you can make this eversion so that the interior of this is outside and the outer one grips it, and that will be keeping the ostium, the distal part, open for that. And at the end of the procedure, you can find that a beautiful terminal neosalpingostomy is completed like this. If you hold it and grasp it and then revert it and invert the outer part, so that at the end of the procedure you can find a beautiful fimbrial-like thing is there, and that is the procedure of terminal neosalpingostomy. That is the end of the procedure. Still some of the healthy fimbrial ends are there to have their functions, but I've maintained the patency. I do not know whether the potency will be there or not. And the other side, again, I'm doing the same procedure, the proximal tubal block with the cannulation, hysteroscopy cannulation, and making both the tubes open. Then I hope that these are the cases where is a good fertility promoting surgery can be there. So the other side, again the cannula is being introduced and hysteroscopy cannulation. With the same thing, you can find the ostium here and negotiate that, and ultimately you find that you can cannulate the proximal tube. So these are some of the procedures. Depending on the cases, you can do it. And remember, the main thing about the results is that the interior pathology of the tube is important for that. So patency versus potency, both are important. Potent, you can make it patent, but you cannot make it potent always for that. So these are some of the cases where both the tubes can be tackled with that. It's not coming down. Now this is another case where again the modified intercessor technique, the role is maintained for that. And this is again another case where the pelvic, as I have already told, the tubes are normal, but around externally there is adhesions, peri-ovarian adhesions are there. So peri-ovarian adhesions, you use less cautery, more of seizure, and do an adhesolysis. So this is a classical thing. You can find out this is most probably some of the inflammatory or post-surgical thing will give rise to this. So you go through the corrective ways and mainly use the less current, and the peri-ovarian adhesions or peri-tubal adhesions are more important, and the results are much better as far as the pregnancy is concerned. So these can be done with the laparoscopy with the minimal use of the current and the seizure, and do the job for that. So these are pelvic adhesions of above the outside the tube and ovary where you can do the job. Now, ovarian, parovarian tumors, functional, you must be the functional versus pathology. You don't operate on a functional cyst. I have seen many patients, I think they go for a radiological report. They say that 5 centimeter or 4 centimeter cyst is there, but it's a functional cyst. You must be saying that only pathological cyst you operate. Of course, benign iota principles, benign and malignant, you must be absolutely be very sure. Mainly do the color Doppler can be enough for that. And you are doing a conjunctive versus radical, most probably a conjunctive. So this is the thing where the infertility patients, and we find that there is a ovarian tumor on the left side of about 12 centimeter, and you can find that you go through the correct cleavage with that and coagulate the vessels so that the bleeding will not be there. and this is the correct cleavage. You can do the cystectomy by traction and counter traction, and that can complete the procedure for that. So remember again, this is not very difficult procedure, but a good space identification of the correct cleavage is essential. This is the cleavage, you find it out, and now you catch hold of that either with the dissector or with the suction irrigation cannula. You just strip it, and the whole of this cyst can be enucleated with that, and you can clearly find out that this is the correct plane, and this is a simple cyst, a unilocular, and this could be one of the cause of infertility, but maybe that many cases you cannot say that is a direct cause of infertility. But an infertility evaluation, if a pathological cyst is found, you have to do a surgery, not only for fertility promotion, but to prevent the complications like a torsion ovarian and damaging the whole of the ovary if there is a gangrene occurs for that. So you just, main thing is that identify the area, the good cleavage, you can puncture it, and then after puncture, you dissection becomes very easy for that, and then remove that part ovarian tumor. This is again another case, a dormant cyst. Again, the dormant cyst, the only difficulty is that the soiling. The soiling nowadays, the theory of oleokeratin granuloma doesn't arise. Only thing is that you do this and then remove it either through the coldotomy, or you can use a lap sac. We are using the globes, normal globes, and we are removing that. And remember that the good lavage is important. So after the end of the procedure, a good lavage is important. And I have seen the pregnancy results in the dormant ovarian cyst is very good for that. And you can find a good cleavage if you are going to the proper cleavage, nothing like it. And the whole thing can be very well enucleated. And then the delivery is a major problem because you have to just deliver it with the lap sac. This is again one case I remember. This solid ovarian tumor of about 10 centimeter diameter. And this solid ovarian tumor, I was thinking there is a case of fibroma. The rest, everything is normal on infertility evaluation, the other tube. And I did this by laparoscopic excision of that. Unluckily, it comes out to be a granulosa cell tumor. So granulosa cell tumor, then is they say that is a granulosa cell tumor. We followed it up as a fertility promoting surgery, and then subsequently say give birth to a baby, and then subsequently the reproductive potentiality is achieved. And I was so happy that these are the cases. I consulted the oncosurgeon, my friend, and maybe that I don't remember whether it's a same thing can be done. But here I find normally when I dissect it, the vascularity is an important part. So where you find more of vascularity, I was suspicious for that, and therefore I did a unilateral adnexation. So there is a place for conservative surgery in a case of fertility promoting surgery, but because the vascular is there, then it comes out with that. But ultimately, it came out with pathology, histopathology, it came out with a granulosa cell tumor, and the other side over is normal. And then she became a mother after 1 year, and then she's happy. Now it's follow-up and all that. This doesn't give rise to any problems. So there is a place for this. Again, this is a case where the vascular, this is a case of a tumor which is a unilateral tumor, which at that time the color Doppler was normal, but on laparoscopy I was very suspecting that suspicious of some stitch of malignancy, although the surface is smooth and all that. So, but the other ovary is normal. So I did the unilateral salpingo-oophorectomy and delivered this through the cul-de-sac, the pouch of Douglas, and then the other ovary is normal, got good toileting, and ultimately then I find the histopathology came as the cystadenocarcinoma. So the cystadenocarcinoma, then the patient was subjected for chemotherapy. The other ovary is normal. The chemotherapy followed up all that, and after 8 months she became pregnant and then gave birth to that. Now she is still under follow-up, and I find that there is a place for the even malignancy also there is a place for fertility restoring surgery for that. Now, pelvic adhesion. In the pelvic adhesion, endometriosis, inflammatory or post-surgical, as I have already told. Endometriosis, I have already demonstrated a few cases. Inflammatory and post-surgical are all adhesions outside the tube, which the results are much better, and the current, you don't use much of the current for that. So these are cases where you can find a hysteroscopic appearance is normal. We do simultaneously as a fertility diagnostic as well as therapeutic. The ovary, you find the left ovary is just adherent to the ovarian fossa, and here it's very easy that you just coagulate that. It could be an early endometriosis also. It's because the other ovarian part, other tubes and ovaries are absolutely normal. So here, with the just releasing the ovary from the ovarian bed, can give rise to a fertility assurance for that. And again, this is another case where the pelvic adhesions are the cause of the infertility. And here we are just for complete thing, we are doing a hysteroscopy, the same sitting with that, the diagnostic therapeutic histolaparoscopy, and then performing the procedure by the laparoscopic procedure for that. So here you find that yes, you can see the adhesions for that. And this is typical of looking like a chlamydia for that. Unlike the other cases, this is a relatively early case for that. But these are all chlamydia where you can find that if the other tube is normal, then you can do a salpingectomy, as we do in a case of the hydrosalpings. But here, the tip, the fimbria is not found. It could be a tuberculosis. And then we find we separated it, and a nodule is found in the right tube. And there are a lot of flimsy adhesions for that. And these are the cases where laparoscopy can be diagnostic for tuberculosis also. So these are the cases where I find that in the right tube, there is a nodule. I excise the tube. This is the tube. And maybe that this tube, I excised it and sent it for the histopathology. And the histopathology confirmed that it's a case of tuberculosis. So these are the cases. The diagnostic Raman value is much more, particularly for laparoscopy. But you cannot find a fimbria. And I've shown that these are the cases where chlamydia is to be first suspected, and tuberculosis is not uncommon in country like India for that. And these are the cases of minimal adhesions. These are minimal adhesions. You see the ovary is adherent, the right ovary is adherent. These are all early endometriosis, and which is really adherent to the ovarian fossa. Just good salping overlysis can solve the purpose and improve the fertility for that. Now, last, I will say that place of conventional surgery in fertility, still it is their practice. Abdominal myomectomy, cervicopexy for nulliparous prolapse, Fothergill's repair, and tubal recanalization. I think these are the cases where a multiple myoma, 28 weeks myoma, multiple myoma, is not amenable. I don't consider that these are fit candidates for laparoscopic myomectomy, and therefore I did a open myomectomy with special precaution on the tubal portion where the anatomy can be restored. It's not be involved. You can see the left tube very close to the myoma for that. It must be very important. And there's a multiple myoma, and all the, as far as the myoma is concerned, all as far as possible, the larger myoma can be nucleated, and that should be the procedure. So there is a place that you cannot say that goodbye to abdominal myomectomy. Still, there is some place for that. Here is again a 30 weeks abdomen is 30 weeks, and there is a solitary myoma, and these cases is amenable for the open myomectomy. And remember, the myomectomy in open, these are the cases where you delivering the big myoma is a major problem. You can deliver it with the myoma screw or with the vacuum. We can using it for that. And then if you are fortunate, the myoma is in the upper segment, it's not occupying the cervical segment. The classical, the tourniquet, I use it for the tourniquet at the lower part, and then doing the myomectomy for procedure for that. So this again a case where is a nulliparous prolapse. These are nulliparous prolapse is you go for either a laparoscopic meshplasty, or you can go for a Purandare's operation of taking a rectus sheath 2 strips of the rectus sheath and fixing it to the anterior surface of the uterus extraperitoneally. It's not a very difficult procedure. I've already shown during the time of the episode of prolapse. But remember again to say, I don't want to waste time for that. But this is a case where a transverse strip of the rectus sheath on the 2 sides are kept behind. And then again, this is a case of Fothergill's repair. This is second degree descent and Fothergill's repair, and a good amputation up to desired limit is essential for that. And after that procedure, the cervix should be absolutely seem to be normal. And the typical Fothergill's procedure repair, particularly for secondary infertility, they present with secondary infertility, and a good technique of repair can be a really not only relieve the symptoms of prolapse, but having a reproductive outcome, good perinatal outcome of the conception. I think this is an important step when there is a place for the open surgery, conventional surgery, rather than the endoscopic surgery. So I've dealt with the details of the endoscopic surgery, but little bit about this conventional surgery. That's why I wanted to point out that it is not gone to the graveyard. It is still there, and this is how you do a colporrhaphy, enterocolporrhaphy, and then reconstruction of the cervix is important for that. A good reconstruction of the cervix is essential by that, and that can be achieved with the Fothergill's repair. And this is again a recanalization, open recanalization. You can do a laparoscopic recanalization, but this is again open recanalization. We do it with the 60 proline on either side. The length of the tube is important, and other pathologies are important for that, for the success of the procedure. Normally, we see that the length of the tube, minimum 5 centimeters, if it is there, then it can be used for that. And these can be a macrosurgical procedure, or a microsurgical procedure, or laparoscopic procedure, whichever is important, you can do it. And this is one way I have shown in my case is an open surgery and microsurgical procedure for that. And lastly, fertility promoting surgery in gynec malignancy. What are those? I've already told you, cervical. Now the most prominent is a radical trachelectomy. Is one an ovarian conjunctive surgery in stage 1, grade 1 disease and borderline tumors and early stage, early grade tumors. You can go for either a unilateral adnexectomy or a removal of the solid ovarian tumor and then giving rise to the chemotherapy and then subsequently enhancing the fertility for that. Now, innovative procedures, again, uterine transplant, one of the, I think, Indian contribution is there. And from Pune technique, I think ovarian transplant, there is a lot of research going on, and few cases have been reported with that. Ovarian reimplantation, ovarian transposition, they go transpose it, and there's a easier procedure of transposing by laparoscopic also, and to the paracolligator. And then ovarian tissue cryopreservation for fertility enhancement for that. So thank you very much, ladies and gentlemen, my viewers, for giving me again opportunity for the 21st episode for that. Thank you. Sanjay, thank you very much.
Thank you very much, sir. And it was a very informative, knowledgeable lecture. And you were sharing your experience and the live demonstration of the cases. So thank you very much, sir. And with your permission, we can take the questions, sir.
Yeah.
Yes. Currently, there are more than 250 live users are there, sir. So many doctors, even at 10 p.m., they are attending your lectures, sir. So the first question is from Dr. Vijay Lakshmi Seshadri. She is from Chennai, and she is asking your advice. Since any residual product can cause a relative sterility in cases of twins with one early reduced twin, with the other twin is ongoing pregnancy, LSCS will give a chance to explore the uterine cavity. But if it ends in normal delivery, what is your advice?
So I think, thank you very much, Vijay Lakshmi, that you are a constant viewer in our E-Gurukul program. But it is not going for a topic. But again, this is a worries about you that I think your question is on a twin pregnancy with one demise. With one demise, can
yes,
you,
sir,
Sanjay? Can I have?
Yes, sir. one is reduced and the other is ongoing.
Oh, now if it is a fetal reduction, embryo reduction is there, I think there is not a problem, because twin demise and first trimester less than 12 weeks, and from 12 weeks to 28 weeks, and late fetal demise, there are three consequences. If earlier to 12 weeks of gestation, either spontaneous demise or you have done an embryo reduction, the affection of the second pregnancy, second fetus is not going to be affected much more, and you can continue that, and no special treatment is necessary. But in mid trimester, if it comes as a second demise, fetal demise in the second trimester, I think the impact of the first impact on the first surviving fetus is much more in terms of ototoxicity, in terms of cerebral. Lot of reported that yes, the cerebral palsy, the mental I think retardation is much more in those surviving fetus for that. And third, the concern is that not much of scientific evidence is there with the development of DIC with that, but that is variable results with the DIC. In the third trimester, the one twin demise.
Yes, sir. Sir, the next question is from Chennai. Jiv Tharani Madhav Rajan. She is asking that 26-year married with symptomatic bilateral chocolate cyst of 7 centimeter. What will be the management, please, sir?
Well, if it is 7 centimeter chocolate cyst and married and is not conceived and presented with primary infertility, say if they are not completed, they are not presented with infertility, just marriage, and within months they find that yes, there is a chocolate cyst. What for? They have done an ultrasound. That's important. Apart from that, see, they must have a dysmenorrhea. The symptoms are there, so that it is identifiable for that. If the symptoms are there, they must be treated. Now, 7 centimeter chocolate cyst, if they present with infertility, I think there is a ample rationality of doing a diagnostic and therapeutic laparoscopic surgery for that. The size always doesn't matter, even with the small size, 3-4 centimeter chocolate cyst. We encourage pregnancy. And give a time for that, but don't leave it for longer time. So don't delay it much more. But in that particular case, because the cyst size is one aspect, the adhesions is important other aspect for that. So to do a tube-ovarian relationship, adhesiolysis, and maintenance of the relationship of tubes and ovaries along with the cyst is important in that particular case. So in a 7 centimeter sized bilateral, I think that there is a real indication for surgery.
Thank you, sir. Again, there are many messages complimenting your lecture, as usual, sir, from all over India. And sir, there is one particular doctor, Dr. Sheikh Mohammed from Anantnag. He has actually 2 questions. One is, he wants to know what is the choice of ovulation induction agent in PCOD. And another one is, for how long metformin can be given in a case of resistant PCOD?
Well, thank you very much for asking questions beyond the topic. Yes, but I'm really happy that you are really interested to see it and be with me at this odd time for that. Well, for PCOD, earlier the oral ovulogence, clomiphene was the drug of choice. Now there is a plenty of evidence to say that the first line of oral ovulogence is letrozole, because the advantage of letrozole is that it causes monofollicular development, so that the OHSS is not there. And second important aspect is that the negative impact of clomiphene on the endometrial thickness and the cervical changes will not be there. So the first line of treatment of oral ovulation induction is letrozole in a case of PCOD. Now the question of metformin. Metformin is really an optimizer for ovulation induction also. So insulin sensitizer, there are a lot of insulin sensitizers, out of which metformin has been proved beyond doubt for long years. And a case where the clomiphene or letrozole is given, if the non-responders, there is no ovulation, and there you give a metformin, provided you don't do a insulin level, but at least a family history of diabetic, or she's obese, you add metformin as an optimizer for ovulation induction, the response is much more better. So in that particular case, metformin helps in augmenting the ovulation, and along with the you can give along with the ovulation, oral ovulations, or you can give prior to oral ovulations 3 months of metformin and then oral ovulations and continue that. And if at all there is a pregnancy, you continue the metformin, and not only for up to about first trimester, because initially what happened, initially the proposal was that you continue, there could be a chance of miscarriage. If you do not continue, the miscarriage is more. And they usually, initially the period was that they advised, the recommendation was up to about 14 weeks. Then these cases were studied. Then they withdraw it. Those cases, they withdraw metformin, they are more liable to undergo they develop the GDM. So therefore, now the current recommendation is that if metformin is given prior to pregnancy, it should be continued till whole of the pregnancy to avoid miscarriage rate, number one, in early, and to prevent GDM in subsequent pregnancy for that. It should be continued.
Yes, sir. Sir, there is a question. She is asking your advice. Dr. Jayasri Sethi from Bangalore. She is asking, bicarbonate uterus with septum 3 pregnancy loss around 10 to 11 weeks. Does she need a septal dissection, sir?
Bicarbonate uterus and septal dissection is completely two different. Bicarbonate uterus is completely two horns, two corners. And septate is normally the midline septum is not there. The resolution of the septum is not there, so that there is a persistence of septum. Maybe a half, maybe 1/3, maybe 2/3, maybe complete septum for that. So here the differential point is that on laparoscopy you find the dome of the fundus is normal, rather broader in a case of the septate uterus, whereas in a bicarbonate uterus, two different identical horns could be found out, which could be attached right at the level of the cervix. So the septate uterus needs a treatment. Septal resection is important. That's I have already told about it. But bicarbonate uterus, the surgical options you don't adopt immediately, because periodic in bicarbonate uterus one observed that repeated pregnancy gradually goes on, and maybe that the pregnancy could be achieved for that. But there could be some instances where there is a place for surgery, where there is a unification of the bicarbonate uterus. Earlier we are doing it open. Now in laparoscopy also we are doing that. In last series of mine in my Mullerian anomaly, I have shown the detailed surgical techniques of how to unify laparoscopic unification of bicarbonate uterus. But a counseling has to be done. Patient is really worried about the pregnancy loss, and definitely she wants that. And the post-operative assurance that, again, what happens, majority of the cases will be giving rise to, in quite a good number of cases, you find infertility rather than the pregnancy loss for that. So this has to be counseled beforehand, and then you can do the procedure of unification.
Okay, sir. There is, sir, another doctor from Bangalore, Dr. Shubha Ural, and she wants to know if there is bilateral endometriosis and extensive pelvic adhesion in a 37-year-old patient with infertility. Then she is asking when we should think about surrogacy.
Now, surrogacy, you think about that, particularly find out ovarian reserve. If the ovarian, normally in endometriosis also ovarian reserve is less, and in a 37 years it is presumed to be less. So these are the cases where surrogacy will not also help, because the ovary is not there, your own ovum will not be there. So in that particular case, I think the option would be, better option is adoption for that. But you can have a donor program for that, and donor gamete program, and encourage that. And prior to that, you can do a surgery. If there is a hydrosalpinx, you can remove it, the hydrosalpinx, and with the GnRH analog, you can go it, and some donor program can be done in that particular case.
Yes, sir. Dr. Ayan Mukhopadhyay from Kolkata, he is asking regarding guidance on the pitfalls of glycine media in hysteroscopy.
Well, glycine is definitely documented to have a ammonia toxicity for that. So therefore, the fluid balance is important. If the fluid balance is more than 500, you become cautious. And if the fluid balance is more than 750, you abandon the procedure. Normally, books say that 1000 ml, you abandon the procedure. And because that is important. So for that, we have changed from the glycine to the normal saline, and we changed from unipolar to the bipolar resectoscope for that. So that is important because glycine toxicity, ammonia toxicity, the central nervous system is going to be affected for that.
Yes, sir. That's all, sir. The other questions are repetitive, like the Dr. Asia from Srinagar. She is asking the best way of managing PCOS.
Best way of managing PCOS is there are three modalities of managing PCOS. First modality is weight loss. Second modality is weight loss. Third modality is weight loss. I think that's a very important message which I will give you, lifestyle changes. And depending on the symptoms, you do it. Suppose an adolescent, unmarried girls, they're more concerned with the menstrual irregularity. So you give a menstrual regulation for that. If she's androgenic, give a cyproteron and menstrual regulator combination for that. And if she wants an augmentation of fertility potential in ovulation, and ovulation is the main thing in PCOS, and you ovulate with either oral ovulogenic letrozole or with the gonadotrophins, or you can go in the last resort as the ovarian vegetation in the laparoscopic ovarian drilling.
Yes, sir. Thank you, sir. Thank you very much.
Thank you.
Thank you, sir.
Thank you very much and good night.
Good night, sir. Another wonderful lecture, sir.
Thank you, Alad. Thank you, Diwan.
Thank you very much, sir.
Thank you, sir. Thank you very much.
I have detained you long, and till late night also you are there with me. I think we'll meet next time with the 22nd episode.
Yes, sir.
Thank you. Thank
Definitely.
Thank you, sir.
Thank you.
Recording stopped.